Okay, good morning, ladies and gentlemen, and welcome to day 2 of the Healthcare World Festival. We had a fantastic start yesterday with our session on infrastructure and the development of healthcare infrastructure in sub-Saharan Africa, with over 1,000 people registered for that event. Hopefully we'll have the same, if not more, today. Today is the turn of digital healthcare. I think it's a really interesting topic, a really prescient topic in the world that we find ourselves in as we start to move beyond the coronavirus pandemic. I think there's an undeniable effect of what's happened over the last 12 months in that we've seen the acceleration of digital healthcare. We were always moving towards a situation where digital would be the primary delivery platform for healthcare, but the pandemic has clearly accelerated that hugely. And what we want to do this morning is kind of have a discussion about where we now find ourselves or where we're coming to in this potential post-coronavirus world and whether we're all aligned on what the future of digital healthcare looks like. To help us do that, we have a fantastic chair in Dr. Nitty Paul, who is a very, very good friend of mine, I'm proud to say, and the Global Medical Director at KPMG, as well as Chair of Harbour, who are an accelerator and incubator for digital healthcare companies in the UK. So, Nitty, over to you.
Thank you, Steve. He's quite right. He's a really dear friend of mine. So thank you, Steve, for having me as the chair on this panel. And I'm so delighted to be chairing such an August panel today. Welcome to all of you. Welcome to the panel and welcome to all the participants. This is going to be an interactive panel. It's going to be lots of questions. Do put your questions in the chat. We're monitoring the chat and we will be taking your questions, your queries and putting them to the panel. So enjoy today. I'm going to go over and let the panel introduce themselves. So first over to you, Anushka. Would you like to introduce yourself?
Hi, Nitty. Good morning. I'm delighted to be here and be part of this event. My name is Dr. Anushka Bachava. I'm the Deputy Chief Medical Officer at Vitality, and I'm also an expert advisor at the United Nations, particularly focusing on artificial intelligence and blockchain in healthcare.
Thank you, Anushka. Mwenya?
Hi, Niti. Good morning, good afternoon, colleagues. It's a pleasure to be here likewise. My name is Dr. Mwenya Kasonde, and my background is emergency and trauma medicine. I currently work as an independent global health consultant for multinational agencies and for the private sector. Thanks.
Sanae?
Good morning, good afternoon to all. I'm really excited to be here with you today. I am a senior advisor to the Health Minister and Minister of Health Ethiopia, and as well as a president for Ethiopian Medical Women Association. So I basically advise the ministry in so many other things. One of them is digital health and digitalization. Thank you.
Welcome. Emma?
Hi, Nitty. Delighted to be here. I'm Emma Sheldon, and I've worked across life sciences, technology and medical devices. And now I'm working as a consultant to help organizations who are looking at their digital offerings and how they can, improve their products and strategy across health.
Stan?
Hi, thanks, Nidhi, and welcome everybody. I'm delighted to be here like everybody else. I'm Dr. Stan Shepherd. I'm founder and CEO of a company called Instant Access Medical. We provide portable, comprehensive, lifelong personal care records. My first degree was aeronautical engineering. Then I went to medical school at 29. So 1 foot in technology, 1 foot in clinical. We became global partner for Special Olympics and so struck by the needs of people with intellectual disability, we reconfigured our GP record as a lifelong personal care record for them and for everyone.
Thank you, Stan. Dan?
Morning, everyone. Dan Morris. I'm a healthcare lawyer and litigator with Bevan Britton, a healthcare specialist firm in London and the UK. And I am the lead for digital health within that firm. Delighted to be here.
Thank you. Simon?
Hi, hello everybody. I'm Simon Swift. I'm founder and managing director of a company called Methods Analytics that I lifted out of the NHS, having run as an NHS function for 4 years. We focus on helping people who make difficult decisions and need to solve problems do that through the application of data and data science and analytics in order to deliver impact and add value.
Thank you so much, Simon. So you've seen, we've got a really August panel. We've got John. Sorry, John, nearly left you out because on the other side of me. Please, go ahead.
Thank you very much. My name is John Hubble. I'm an investor in health innovation. I have two interests, one in personal health and one in digital health. My interest is investing in personal care pathways that combine digital and physical health solutions that promote wellness.
Thank you, John. So you can see we've got a wealth of expertise here. So keep your questions coming in, participants. We'd love to hear from you. So the first question I'm going to pose to the panel, and whoever wants to answer this, go ahead, because you're all global citizens. What are the key global trends you guys have seen in global health, particularly as COVID has accelerated this whole journey? Anyone want to take that? Please raise your hand if anyone of my panel wants to take it. Emma, go ahead. You're on mute. Please go ahead.
Thanks, Niti. I think the thing that strikes me the most is the confidence that people are starting to have in the data that drives the decision making. And that really comes with the mindset that allows people to have confidence in it as much as the technology behind it. So I think one of the trends really, I would say, is around the patient care data from something like stroke, and looking at the AI and the diagnostics that allow decision making to happen, and that being much more widely accepted than it's ever been before, or around patient flow and decisions about how care is delivered based on the data. And also then just patients themselves having more confidence in the technology around their own healthcare and being willing to ask about, you know, the interventions that are needed based on their own knowledge. So I think confidence and mindset are two really key things that stand out for me.
Thank you, Emma. Anushka, would you like to take it from a South African perspective? And I'll come to Muenia and Sana next.
Sure. So I think I agree with what Emma has said previously. I also think that the acceptance of digital technologies in delivery of healthcare has changed significantly. Prior to the pandemic, banking and other sectors like e-commerce had moved into a digital gateway where they interacted with their customers and consumers through digital platforms. And we had transitioned quite slowly into that environment, but you know, COVID has catalyzed that predominantly in healthcare, where the majority of people prior to COVID had probably heard of telemedicine and probably accessed video GP, or at least heard the adverts on the radio of the various providers in various health ecosystems. Most still warranted a visit to a physical clinic, and COVID has changed that and shifted that for now that, you know, people of all generations and all ages are willing and happy to engage with telemedicine and virtual GP consultations. I think the majority of firms have seen at least a 300% year-on-year increase as compared to pre-COVID. And in addition to that, I think the technology isn't just being used now for video consultations. We're seeing, as I'm alluded to, and I know fellow panelists will agree, electronic health records becoming more and more important, people being more aware of their health and more interested in wellness and prevention and such methodologies, and people in fact interacting more with wearable devices to track their health, be it the Apple Watch, the Garmin device, or others. And I think that's a fascinating shift in the psychology of consumer healthcare.
Thanks ever so much. And I'm just going to move to, sorry, Dan, you wanted to come in there. Please go ahead.
I mean, I was just going to say, I think obviously the pandemic's massively accelerated digitization. I mean, it's the perfect storm. And I recently read an article that took this maritime analogy further and likened digital health to a ship in a harbor, which is safe, but that's not what ships are built for. In other words, we all know the tech's been there for some time, but it's only when you get out on the seas in that storm, you see the true potential for digitization. And I think in the UK, certainly the biggest winners in digital have been those that have simply allowed the world to keep turning. So solutions to support online outpatient consultations, secure clinician messaging to support remote working, and shared care record usage, as well as obviously the virtual team meetings. But I think, you know, old habits die hard as well. And one commentator here in the UK recently remarked that one of the biggest tech winners of the pandemic has been the 145-year-old telephone. You know, we're still seeing a lot of the appointments being taken up via telephone for GP, and the percentage of video consultations is still less than 1%. So I think we have to bear that in mind as well.
Thank you, Dan. And a word of lovely pragmatism that arose there. Can I just come to the low resource settings? Dr. Sanae Moenia, what have you seen in low resource settings? And others, please chip in. I certainly have done a lot of work in about 8 different countries with AXA EC, and we've seen some very, very startling trends in those countries. So over to you, Dr. Sanae.
Thank you. So what we're seeing around here is people are more interested in the data source than the data, and the legitimacy and the cleanness and the accuracy of the data source rather than just the data and analyzing it. So that is the major shift that we're seeing here. But in both communities of the patients and the providers, what we've seen is people are becoming more comfortable to exist virtually and kind of to avoid physical contacts, physical meetings, and more of virtual existence. So that is another thing that we're seeing now. We're also seeing, digital health has been in its infancy even before the pandemic, and I cannot say it is well developed even right now. But we've also seen patients becoming more engaged and wanting to be more informed and to kind of have their unique ID, unique history, and becoming more informed about their own health. So these are the major shifts in trends that we're seeing. From the government perspective, now we're digital health and the entire data management, information revolution has been a major area of focus even before, but this pandemic has accelerated the action towards those initiatives as well. Thank you.
Thank you so much. Can I come to John? John, you when we got started in the beginning, you talked about some of these innovations. What have you seen? You've seen some global innovations and trends, yeah?
Yeah, so my innovation experience is with basically in the very early stage of innovations, where government agencies, in industry, and academic institutions are putting lots of funds into innovation, and there's no lack of innovations to invest in. The big issue is that investments are going into the ideas and the potential, but not into the actual functionality of the businesses, and therefore, I mean, the stats that 90% of all angel quality investors and 75% of all VC quality investments are failing after the second year. So there's lots of innovation out there. I think money is going into the wrong place in these companies, and it's a shame that you see in a large academic institution hundreds of very, very good deals, and not many of them make it past the second year.
John, that's an indictment, isn't it, of both the commercial interests and the ideas interests, and some of that coming. We see that in Harbour quite a lot. We get a lot of the early ideas. We haven't seen many businesses that have taken it through to Series A, even pre-Series A, and to Series B. So that's a trend we're seeing. But I think that possibly might be accelerated. John, do you think that might be that?
Actually, we've put our last 2 years of time into designing our own platform, our own fintech platform that puts the analysis and the money in the right places. So we're hoping that this whole failure rate we can reduce significantly just by basically providing what we call a prospectus quality offering for deals of this size, which are unprecedented, and spending the time on the analysis rather than on looking at the potential.
Yeah, great, thank you. Simon, you wanted to come in on this, and I think the data question was raised, so I'm going to bring a few folks in on that one, but go ahead, please.
Just on that, I'm having a lot of conversations with people, and one potentially negative effect of the excitement around digital healthcare that's sort of secondary to the pandemic and the massive acceleration of usage is from a commercial point of view, from a investment point of view, the market's very frothy. there are a lot of people running around with all sorts of ideas. There are a lot of investors who are very excited, but don't quite have the depth of knowledge and understanding to know which of the excitable tech heads running around actually understand the market and the potential, and which ones are excitable but are never going to go anywhere. So I think there's a bit of, sort of froth and bubble and mess, which is wasting effort and money that needs to be sort of looked at quite carefully.
Thanks for that, Simon. I think coming back to the data question, I think some of you raised that. I think Emma started that dialogue. So, Moenia, would you like to talk about the data, and particularly what I'm interested in to hear, and we're getting some questions coming in on the chat, is how is that going to be usefully purposed for patients? Just Moenia, Stan, and then Simon wants to come in on that as well. Moenia.
Thanks, Niti, and thanks for the valuable contribution so far. So let me just quickly touch on your previous questions and now relate it onto this data question. And you've talked about innovation specifically globally. And Simon said something very important is about the knowledge and understanding specifically of the local context. I think for myself, I come from Zambia, and when I always have these conversations, I always like to bring it back to the basics and bring it back to the importance of contextualizing anything that it is that you're doing to the local environment. I mean, again, I come from Zambia. Let's talk about Africa, for example, a very exciting continent. We know a lot going on in terms of data and digitization of healthcare. I'm currently working on a project that is working on digitizing civil registration in Malawi, for example. A lot of exciting innovations going on. But people have heard me say this so many times, and I'm going to say it here again today. You cannot digitize a facility that has no electricity. I mean, you'd be surprised by sort of the level of, the advancements in terms of basic infrastructure that exists across the continent. So you really have to put that very much into perspective. And again, to add to that, some maybe slightly more on the positive side, in Africa specifically, we're seeing a lot of advancement in terms of mobile penetration. Africa, we all know, is the youngest continent, on the planet, with about 60% of the population being under the age of 25. So this brings very exciting opportunities and advancements, that are available in terms of digitization, of healthcare specifically, as we are talking about today. And then let me relate this to data. So you've heard it said time and time again, you cannot improve what you cannot measure. So again, timely, accurate, and secure data really are the foundations for making very much evidence-based decisions, and importantly, allocated resources effectively, and of course, tracking communities left behind. We also need to think about the status of health information systems, as mentioned, using statistics, research, digital technologies, of course, and other types of data that will really reflect the accountability to meet the needs of marginalized people, specifically in emergency and non-emergency contexts. And lastly, to close, I'll just give quickly again an example from Kenya, where the mobile giant Safaricom, along with Farm Access and CarePay, have launched what they call M-TIBA, which is a mobile phone-based healthcare financing product. And this provides low-cost health insurance to local communities. So you can imagine the data that has been generated from such innovation, and of course, the ability to track communities left behind. The communities that are marginalized are often the ones that suffer the most in terms of needs, in terms of healthcare needs. So this is just so important, and I'm sure there'll be plenty more to say today. Maybe I'll stop there for now. Thanks.
Really important and interesting contribution there, Moenia. Stan, I'm going to come to you for in a minute. Really, on your kind of low resource settings and the examples you've given, it's the same that we are seeing. With AXA, we bundled health insurance with lots of, not just health insurance, critical illness cover alongside of telemedicine in 8 different countries, and interesting results that were very different in different countries depending on who the distributor was. We partnered with an MFI in Egypt, and we got the best results there because it is a combination of the physical and the digital, the click and brick, as I'd call it. So Stan, over to you. Your point on data, you've done a lot of interesting stuff on records. How would you see this?
I think the key 2 themes are data and patience. So what I'm going to say is relevant to data, but it will interdigitate completely with the patient. I mean, the key thing about the data is to share it, not to keep it in one place, not to restrict its use. And I think we have to put the data not only in the hands of patients, but we must put it in the hands of patients. We're quite safe there. The statistics are something like 75% of us book our flights online. And in the UK, it's only about 5% who interact digitally with the NHS. So we know there is no problem amongst consumers for interacting digitally. There is no problem there. And as Wena said, you know, if you've got a country like Africa with 60% young people, then that's not going to be a problem. So we need to change the center of gravity. And I don't think it's about patients. It's a big privilege for patients to see doctors' data. Of course, there's value in that. But I think we need to change the center of gravity. So it's about doctors seeing patients' data. And I think we need to accept and agree that the patient is the primary data owner. Nobody challenges the right for consumers to hold their own bank and credit card account details, and that led to open banking. So we need to, the biggest lesson for me is to let the citizen, the patient, really be at the center of it. And there's more to say later on other questions I know you're going to come to. But for now, as far as the data is concerned, let the data be shared. Let's share it particularly with the patient. And for example, healthcare professionals spend a disproportionate amount of their time monitoring normal results. As a GP, every day you go through pages of results, most of which were normal. It's a ridiculous waste of a doctor or nurse's time. Let the technology monitor the normals and then use exception reporting for the abnormals to alert the doctor or nurse and the patient. So for me, data really needs to be patient-centric. There are plenty of other people who can derive great value from the data, but we must put it in the hands of the patient.
So I'm going to move to that bit of it. So you mentioned it. John wanted to come in on that as well, and I think Anushka does. But I'm going to just carry on that discussion with you, Stan, on patient, on data, and the interesting solutions. So in recovery and restoration of healthcare services, I don't call it restoration, I call it resetting of healthcare services. We see that across the world that I inhabit, both from a primary care perspective, but also from elective care that also needs restoring, and from a perspective of chronic disease management, where patients are leading their own technology solutions, like the open APS community in the type 1 diabetes field, where they've created their own artificial closed loop pancreases. So what do you see? And I think you started opening up that box. And what do you see the role of the patient in designing their own solutions and the health system in responding to that? I'm going to take you, Stan, on this one. I think John wants to come in, Anushka wants to come in. And perhaps, Dan, you as the lawyer might want to come in and say where the regulatory aspect of that sits.
Well, I think thank you, Niti, for giving me another chance on this one. I think you asked the question, how can we help patients design the solution? Well, you design it by using it. What we've got to do first is get universal usage of the data by patients. And from that, inevitably, will come a wealth of ideas. So we don't sort of put the patient in the corner and sort of get a microscope out and sort of try and examine them. We will learn by utilizing, we'll learn by using the data, get the data in the hands of the patients. You know, and to give you you talked about the diabetes one. I mean, the next huge wave to hit healthcare is going to be patient-generated data. Now, in the best run diabetic service at the moment, run by healthcare professionals, we see somebody every 3 months. So you see a patient 4 times a year, 361 days of the year, they're on their own. And you say, hi, Mary, your blood pressure's raised, or your sugar's raised. What have you been doing for the last 3 months? Well, Mary has no idea what she's been doing for that. I can't remember what I did 3 months ago. But if we have patient-generated data, and patients have got their own blood pressure monitor or their own glucose monitor, and you say to them, when you have an argument with your partner, check your blood pressure. When you've had a nice country walk, check your blood pressure. When you've had a good sleep, check your blood pressure. When you've not taken your tablets, check your blood pressure. So you start to associate their personal behavior with those parameters, because the problem with long-term conditions, diabetes, hypertension, etc., is we don't feel any different whether our sugar's high or low, and apart from extremes, or our blood pressure's high and low. So patients have no feedback loop. The only way we're going to get patients to get control of their long-term conditions is for them to learn to associate their behavior with their parameters, and that's called put the data in the patient's hands.
Thank you very much, Stan. John, you want to come in, Anushka, yourself, and then Dan, and then I'm going to move on to and Simon wants to come in. Sorry, Simon, I saw that hand. I should have responded to that. John.
So yes, of all the panelists, I've met Stan Shepard, and we've had many, many discussions, and I've learned a lot from him, to tell you the truth. And one of the things that I think, just on what Stan had said, by taking this data that digitalization can focus on, it allows for the physician, for the laying on of hands, and that placebo effect of healing. And so combining the digital that focuses the issues and allows the physician to spend the time in healing rather than questioning, I think is important. Other than that, Stan had raised most of the points I wanted to.
Thank you so much. Anushka, you wanted to come in on this one?
So I wholly agree with what Stan and John have said, and then they've provided a very interesting perspective. I think one of the key areas that I struggle with data in our system right now is data fluidity, and how do we enable data fluidity to flow between the payer, the provider, primary care, secondary care, tertiary care. If we can crack that and give patients the access to control their data, we can better resource our healthcare systems. And what do I mean by that? I mean, as Stan alluded to, risk stratifying populations so that we have low, medium risk indicators and high indicators, and then offering targeted interventions at each of those levels for our patients is how we better use and utilize the resources available in health systems, which are all overburdened, as we know. And I think for me, what the most interesting area is the low to medium risk I guess segments where we can use technology, we can be visionary here. To Stan's point, what we don't have is a holistic view of patients' data. You know, when you're online, you have a holistic journey that's tracked from whether you're using Amazon or Facebook or Instagram, and then you have preferred targeting of messaging. How do we bring that into healthcare? How do we get a holistic view? How do we use the Amazon Alexas or the Google Homes or the TV to nudge people into healthier behaviors? And I think if we can crack that with the data fluidity, we'll achieve much better health outcomes and raise that education awareness piece that Stan was talking about.
Thanks, Anushka. I think, Simon, you want to come in. Dan, you first. You're the lawyer here, and the lawyer in you. What does that say? Obviously, in just on that kind of open APS community that I'm very closely involved with, the first thing that the FDA did was to clamp down hard and said you can't use it, and the patient said, "Well, we're using it anyway, what you can do about it?" And the last meeting I went to, the FDA were present with their chief regulator there. So Dan, what's your view on that?
I mean, obviously I can only talk from a sort of UK perspective, but I think there's no doubt that the regulation and legal requirements around data flow and data exchange are hugely complicated. Obviously, during the pandemic, there has been some legislation which has allowed data sharing to occur, and I think there's broad recognition that needs to be taken through to the future. I mean, we've had the CEO of NHS Digital saying as much. I think, you know, the conversations we're having in my firm about often commercialization of data and how to monetize data that's being held, it seems to me that patients are prepared to accept the use of and commercialization of anonymized health data, but only under certain conditions and certain requirements. And it seems to me that, you know, the key messages were coming out from patient advocacy groups, citizens, juries, and other research is that where there is a benefit to broader society, people and patients are going to be more accepting and forgiving of data use. But where it's lacking in transparency and intended to advance corporate interests and shareholder returns, I think they're going to be less forgiving. And you know, that is quite clearly because data and the security of data raises vital questions about security, trust, and indeed equity. And I think unless we address those, the regulatory and legal framework is never going to get to grips with this. So we've got to start from the bottom up and I think work upwards from that.
Thank you, Dan. And that's a very sensible approach. But we're getting a lot of questions on the chat. Simon, I'll come to you in a minute. We're getting a lot of questions on the chat. We're getting a lot of support from this. Winnie has just talked about having this data available, mentioning to put data responsible into patients' hands. That's exactly what one of the participants is saying. Currently in South Africa, students have developed an app for patients to report any side effects. So again, I guess we need to forge close relationships with, on your question, John, a comment coming from Elaine. Need to forge close relationships with development banks, communications and infrastructure companies like telcos to develop with to help crack that internet area as well. And Moena, your question, if you don't have electricity, what you're going to do with digital? I've been working with a satellite provider, satellite telecommunications provider, who's helping some African countries to set up their own kind of infrastructure based on a satellite rather than having to rely on the internet. So I'll come into you in a minute. Simon wanted to come to talk about this as well. Simon, over to you, and then to you, Muenia.
Thank you. There are lots of things that different panelists have spoken about over the last few minutes, which I think are really important, and you can almost weave together to see how a fabric can emerge. I'm a huge supporter of Stan's paradigm shift, where the individual needs to become the data owner and data controller, because one thing that will do is it will radically improve the quality of data, because I can look at data about me and I can immediately say if, well, actually I didn't have that test, or well, I didn't even have that appointment. So errors can be captured and cleaned much more easily. The second thing is talking about, Dr. Anushka was talking about segmentation and targeted approaches. So this is an area we're very interested in, but I would take it one step further, and you need to understand impact, because I have a ton of data scientists and statisticians, and we can build stratification models, that are gloriously elegant and beautiful. But unless we have an intervention which can impact on somebody's risk, then we're all wasting our time and money. So understanding impactability at an individual level, and it's complex, but it can be done, is the vital thing. Because lots of people come to me with all sorts of exciting ideas to do analysis and maths and fancy things. But my immediate question is why? What will it deliver? What impact will it have? And unless you can really understand that, if we analyse this group of patients, we identify the people at low, medium, high, very high risk of whatever, and we have this intervention for this group, this intervention for this group, and this intervention for this group, which are proved to make a difference, unless you can get to that point, you shouldn't roll out, because you're just going to be wasting money.
Thank you, Simon. Muenia, you wanted to come in, and I'm going to bring in Dr. Senay, and I'm going to ask a question around governments in a minute. So Muenia, over to you.
Thank you. I also want to pick up on Stan's paradigm on the issue of sort of patient-centered data. And just to add to it as well, for me, the importance of participation from communities really is key in all of this. Communities need to be engaged in the collection, analysis, interpretation, and use of data. And the reason why this is particularly close to my heart, again, I come from it from a sub-Saharan African sort of point of view, is that we're going to need to be able to collect disaggregated data in order to truly identify who is being left behind and how we can address those needs. Disadvantaged population groups are often ignored in a lot of different healthcare interventions, and the way to identify those groups and address these inequalities is through the collection of disaggregated data as well as anything else. Thanks.
Thank you very much. I'm just going to I keep bringing in the chat. There's lots of very interesting comments coming in on the chat here. One is from Jane Reed, and she talks about points are well made. However, I think it's also important to consider the older generation who don't feel comfortable having remote medical intervention. So how can we address this, as I feel things can be missed, or they don't trust technology? So again, I think we've talked a little bit about data, but there's a question about trust. I guess some of it has been picked up in some of the points that you've made. I'd like to take Dr. Senay to answer that question, because I think governments are tasked with that, right? So they are the custodians of that trust, particularly in health systems where it's so important. Dr. Senay, what's your comment on would you like to comment on that or expand on that point?
Yeah, thank you. I basically agree with my fellow panelists are saying, but I think we need to also bring the perspective of digital literacy here. So people are becoming more engaged. People want to be part of their treatment as well, and part of their follow-up in their management. But that has to be balanced with their level of digital literacy, how much they can, contribute to the data that is generated from them, and how much they can be in control of their own data. So I think that's one thing we're really struggling on in Ethiopia as well. People they want to be engaged, they want to involve in everything, but how much they can engage depends basically on how much they can use the technology and how much the technology is also available, including cell phones, not only infrastructure like electricity or connectivity, but also having a smartphone which you can directly engage is very difficult. So for other solutions, for other digital solutions, we are trying to use direct call, text messaging, so that people engage more. And we're also trying to do the same in the healthcare as well. So that's the perspective that we're in right now. And I also take on the segment of the population. But in Ethiopia, the problem is not only the segment of the population, the digital literacy, the level of digital literacy in general is very low. So it comes back to one point of contextualizing and customizing to the locals. So that's what we're trying to do. And that's, I think, what the government should do. For any technology, for adopting any technology, is it customizable and is it adaptable to the local context, and also can it be scaled? I think should be the two questions that governments need to answer before utilizing any digital technology. Thank you.
I'd like to come to Emma. Emma, you help a lot of folks kind of in that intersection in health, in folks that are looking at the life sciences as well. Would you like to respond to that kind of, how do you help those folks when you know your customer at the other end may not trust exactly what you're trying to offer? And goes back to a point that John made as well on, there's lots of good ideas and a lot of them are not commercialized for whatever reason. So over to you, Emma.
Thanks, Niti. I think I might use an example here that was, sort of used in real world in the pandemic. And that was the NHS responders, which also linked with the Good Samaritans app. And what that did was it provided a matching service between need and provision. And, it's reasonably low tech. The technology existed. People were engaged on an app, but they actually then used as Dan said, the 145-year-old technology of a telephone to get to those people who were in isolation and to start to head off some of those physical or mental health needs that might have arisen when people were suddenly sort of put into isolation with difficulty of getting to those people. And so what I would say is it was a really good example of something that was implemented quite quickly, which matched, did that sort of matching between volunteers and people who were in need. And, to the points that have been raised there, I think that gave a level of trust. It didn't change people's experiences because those people in isolation were still getting calls. They weren't having to engage with different technology, but it was using the force of kind of a new wave of volunteers to apply to a problem which otherwise would have been pretty difficult to solve. And so I think that's a good example of where there's a matching of, not having to engage people with different technology at the other side, using something which has been implemented to make a difference, and is pretty low hanging fruit, in the sense that we're not having to, to do something very different. So I think that's quite a good example of where, we sort of stepped in and made a big difference, really, and sort of scooted over the requirement to engage with new technology.
Thanks so much, Emma. A really interesting take on this. And Stan wants to come in on that. Stan?
Thanks. I mean, for our work with Special Olympics, although they had intellectual disability, they have appalling health outcomes, as everybody knows, with people with intellectual disability. But what we learned was that those appalling health outcomes are the same, irrespective of the cause of your disadvantage, whether it's poverty, illiteracy, displaced populations, indigenous populations. All disadvantaged populations have almost identical healthcare problems. So our very strongly held view as an organization is that as far as the personal care record is concerned, we all need the same power and functionality in our personal care record, whether we're rich or poor, privileged or disadvantaged. We're, as human beings, we've got 99% in common with primates. We've got 50% of our genes in common with fruit flies, let alone each other. So the need, the power and functionality any of us and all of us need in our lifelong personal care record is exactly the same. They're all different, but the power and functionality is the same. So we believe very strongly the only difference that affluence should make on your personal care record is the device you use to access your personal care record. It should be the same type of personal care record. So we're putting our personal care record in a whole range of devices, right through from the top iPhones through text phones to something we call the green LED, which is a bracelet which requires you neither to have electricity nor internet. Now, this isn't the place to expand on that, but actually, as far as universal health coverage, as far as making data available, we have our very strongly held view is that whether you're rich or poor should make no difference to the power and functionality of your personal care record. Clearly, the world has vastly different affluence levels. We can't control that, but that affluence level should only affect the device you're able to use to access your record, not the functionality of your record.
Thank you, Stan. And I think that's a point well made. But I was going to bring John in here. John, there's lots of questions coming in here around the funding of this. And when the first question we took with you on, and there's a lot of folks here from development, from a lot of folks here from development banks that are giving in, that are putting up debt. I see somebody who contacted me before the seminar to talk about this. Really, I'd like to come to you with a question around, you said measuring impact, whether this is going to be commercial and analyzing that, particularly on some of the social impact funds that I've been in touch with. Sometimes that takes a very long time to come to a conclusion about what that is. And we end up with is it going to make money? And we don't do the rest of it. So I'm being deliberately provocative here because that's what the questions are on the chat coming in as. So over to you, John. What do you think in digital health, the trends that you've seen, how are you guys going to, the investors, and Dr. Sene, from your side as well, from governments, going to make sure that they analyze this properly, these trends properly, to invest in the right things that reduce inequalities and makes for a better inclusive world? Over to you, John. Big question.
Well, for our business, the first thing we looked at, how I met Stan Shepard many years ago was that I was had my very first aging issue and decided to become an expert in aging and how to reduce your biological age. Many years later, we invested in a company that was developed at the University of Toronto, which was a translational health specialist. And so we base all of our research and all of our investment decisions around this process for health. So using the whole translational health process, which validates and verifies the problem being solved and the solution, and then adding that onto traditional business valuation and viability checks of the business. So I mentioned this earlier. We, as an investor, invest in the analysis process. And then once we are comfortable with the analysis process and comfortable of the validation and verification of the business opportunity and the viability and the valuation of the business, that's what we invest our money in. And then we bring our investors in to come into a project that has been thoroughly analyzed. And I guess that's it. And the whole process of this was catalyzed by the fact that of what I mentioned earlier, is the huge failure rate of these startup businesses. So I would say that the investment in an innovative early stage or startup business should be made into their vision and the problem that they're trying to solve and the solution that they're doing, and looking at that and how that can be commercialized in a safe fashion.
Yeah, and I guess the same applies to any payer, right? So I think, Dr. Anushka, you touched on it from a perspective of an insurer, and from a government's perspective as well. And my question would be then, John, Sene, and Anushka, is how can the government play a role in this just like the governments have played a role in getting vaccines to the consumer, how governments are playing a role in trying to look at COVID medicines and repurposing old medicines, I think this is just as vital, right? This is the digital response to healthcare is just as vital to democratize healthcare. So what is the role of the payer in general? You talked about it from an investor perspective, John. I'd really like to open up this question to the rest of the panel. Whoever, I think, Simon, you wanted to answer something, but I'll go to Senai first and then come to you, Simon, and then Emma.
Thank you so much. I think this is also a very critical point in the entire digitalization of health. I think the most important thing that the government should do and what we're doing in Ethiopia right now is engage the private sector, engage investors, engage private providers in the development of strategies, in the development of standards and regulatory frameworks, so that they understand where we want to head and where we want to get and how we want to get there. So we strongly believe that the private sector is a key actor and key player in the digitalization process as a whole, but also particularly for health. So the government actively supports startups and new innovators, even if they're not registered as business, but new innovators, particularly in response to COVID. We've whomever have an innovation, whomever had a solution, we just bring them on board and we engage them and we lead them to incubators and accelerators so that they get the support and develop their innovations. At the same time, we also employ their innovations in a daily response to the pandemic, so that we see how that can be scaled and that can be, the government pays for that. So I think the key aspect here is engaging the private sector in every process that we're taking forward.
So and that's a very forward-thinking view. So Simon, you wanted to come in, Emma, and Anushka, I think you want to come in. So Simon, over to you.
So there were two things that were being discussed. One was about what is the government's role?
Yeah.
And the second one was how does this change payers and investors' responsibilities and approach?
Simon, I'm sorry to interrupt. My question was also around the government acting as a payer.
Yeah. So bringing all of that together, investors, government, and payers if it's not the government. And I think you can bring all of those together with one word, and that's measurement. So an investor should require whoever is coming up with an idea in being invested in to formally evaluate the impact of whatever it is that they think is whizzy and shiny and wonderful to demonstrate impact. Governments, instead of old-fashioned payment for activity, pay for value, pay for impact. Yeah? It's the same thing. It's using the data that digital methodologies mean happens. It's data exhaust. It's a byproduct of clinical workflow, of engagement, of using data solutions, digital solutions. Use this data exhaust to actually measure the value that's being delivered, which builds the case for a business that John's invested in, or demonstrates to Senai that what her government has funded actually is having an impact on the citizens.
So Simon, thank you for that. And I will come back slightly on that. The countries that I work in, many of them don't have data. So, getting that kind of data that you're looking for sometimes is really hard to find. Even in actually middle income countries, that's really hard to find. I'm working with one system that has plenty of money, but no data. So coming to Emma and then to Anushka.
Yeah, I think I very much agree with everything that's being said here. And whilst it's difficult to get data necessarily, it's not difficult to get experience and sector knowledge and advice if it's applied correctly. And I just would flag the number of headlines that I see around how much money a business has got, and that's a headline in and within itself. What I don't see is how much support they've got the other end to kind of, make those products, services, technologies impact real. And I think we need to shift our beliefs around what a win is. You know, a win isn't getting a large amount of money into something that dissipates into nothing. A win is about, you know, really getting something that's going to be supported. And I think the points that John, Simon, Sine are making are, you know, very, very valid, and need to come with the backup of, you know, real good support from governments to help that, you know, and individual private sectors, to help put our arms around these amazing technologies and actually give the impact that they promise.
Thank you very much, Emma. So Anushka, from your perspective, and I'll come next to John and then Stan. And Dan, I'd like to bring you into this conversation because the regulator is really important in all of this. So Anushka, from your perspective, you know, you've heard all this debate going on the, and I brought in government, and you work with Vitality, a really successful insurer. So I'd like to bring in the kind of that perspective, or a UN policy perspective, if you'd like to bring that in here.
Sure, I can share both perspectives, Nitty. I think you raised a really interesting point. What happens with areas where you don't have data, or the data is inaccessible, or the data isn't in the right structure, form, and such like in the right hands to be able to make useful insights? And I think it's not really just about data. I think there's a huge issue with the 5 Ps, as I call it, be it politicians, payers, providers, physicians, and there's another P, pharma. You know, there's a huge issue between all 5 of them acting territorially and not breaking down barriers. And our key opener here is, how do we foster collaboration across the system? Because at the end of the day, if we have clear collaboration across the system, we can create real user experiences. And to Simon's point and to Emma's point before, user experiences that deliver and create value for healthcare, for governments, and for the consumer, which is the patient. Within Vitality, we see ourselves and want to be and aspire to be a test bed for innovation. And I believe that's a role any organization can play in encouraging and startups towards, you know, accelerating their development and becoming a success in the current healthcare environment, which is a challenging one. And I think there are the ways we can experiment with innovation, and part of that is through, you know, joint ventures, shared equity models. I'm sure John has some stuff to say on this. Shared expertise, acting as advisors or board advisors, you know, introducing new pricing structures so that it's not just a pay per member or per member per month model. It's value-based pricing, and Simon touched on this in addition, that really can offer these new innovations an opportunity to succeed and allow them to thrive. So for me, I think it's about 3 things. It's breaking down the barriers of communication and allowing for real collaboration across the healthcare ecosystem. I think it's about all of us within the system understanding who are the guardians of knowledge, who are the guardians of data, who are the guardians of information, and what can we do to potentiate public health messaging, particularly in terms of in times of crisis like the one we've just experienced. How can we educate and raise awareness with the customer segment groups that we interact with? And thirdly, it's really about thinking outside of the box. I hate that phrase. I think it's an awful phrase, but you know, let's challenge ourselves into building new business models, new payer pricing models, new commercial agreements to support these budding entrepreneurs, because that is where the value really is in the ecosystem. Budding entrepreneurs that are putting their lives and their, you know, their own you know, careers on the line to come up with these ideas. I finished with one final point, and I support John in saying this. Not every entrepreneurial journey is a successful one. I myself have had several that have failed, and I'm a proud failure in that aspect. And I know Nitty yourself is probably similar. And not every entrepreneur needs to be lifted and had a light shone upon them. I think we have a lot of silent entrepreneurs in the ecosystem doing some great stuff. And they're pretty happy and content doing their great stuff. And I have the opportunity to work with some of them. So I think we need to find the ones that are commercializable and monetizable versus the ones that are happy just, you know, taking them in the background and not looking for acquisitional growth.
Thank you so much, Anushka. Really interesting perspective. So John, Stan, and then Dan.
So what Simon says, measurement and impact. And this may be a request, a challenge for our audience, is that we are putting together an innovation scorecard that looks at the businesses ability to become successful. And we have brought together an innovation, a group of specialists. These are all academics and business people. That one is an innovation specialist working at one of the largest campus accelerators in the world. One is a professor of epidemiology, if I can pronounce it, epidemiology. We have a professional evaluator, a chartered accountant. We have a deep tech expert. We have the translational expert and an impact expert that we've all brought together to analyze the scorecard, looking at the validation and verification process, and then the 10 stages of business and how a business fits into that to measure success and measure impact.
Thank you,
potential and risk.
Nicely said. I think Stan wants to comment on that, and then Dan.
I won't go too long. And taking Simon, Nitty, and others' points about the lack of data, what we can do is measure outcomes even in the short term. And one of the problems is that many, if not most, payers pay for processes rather than outcomes. And the best example of a difference between the two was what I saw written on the side of a taxi in Los Angeles. And what the guy said on the side of his taxi was, "Your money back if I don't get you to the airport on time." And I thought that was absolutely brilliant. What we all want to buy is the outcome of getting to the airport on time. We don't want to buy the process of being driven there in a taxi. And for me, that illustrated the other difference between process and outcome. When somebody buys a process, that payers can't stop interfering. So if you get in the taxi and he says, "I'm going left," you say, no, go right, go right, go right. All right, because you're paying for the process. He goes your way and you end up missing your flight. If you buy the outcome of, "I'm going to get you to the airport on time or you'll get your money back," you don't interfere with him and tell him to go left here or go right there. You let him drive and get you there on time. So when you buy processes, payers can't stop interfering. When they buy outcomes, they stand back and let you get on with it. Thank you.
Yeah, and again, kind of done universal healthcare in so many countries. That's the holy grail, right? And we're getting a lot of questions on value. What do you call value? How do you define value? What is it? What does value mean? And these are the same questions that I get in every healthcare system that I've been in. So Dan, I'd like to bring you in on this, because not just with your legal hat on, you've done such a lot of this work with payers as well as providers.
I just want to pick up on a number of the threads that we talked about, the sort of digital exclusion, what is value, the payers and the role of government. I think you've got to acknowledge that, the issue of digital exclusion, it's not about just the lack of IT, the lack of digital skills, IT infrastructures, internet access. It's also that digitization of healthcare is probably easier in some areas than others. And what I mean by that is there are some health conditions which are inherently more complicated, more multifactorial, less prevalent. And the suspicion is that these often get less attention from developers, funders, because a digital solution in these sorts of areas is going to be more difficult to develop, it's going to cost more, it's going to be less profitable. And I think you have to look at the difference, for example, between the proliferation of digital solutions aimed at physical health as opposed to mental health. And you can probably get the idea of what I'm talking about here. And this is where I see the role of government and policymakers. It's to make sure that there's this evening up so that all the areas of healthcare that we want to be, to see innovation in, can get that. There's adequate funding, there's incentives to offset the sort of pure commercial imperative to ensure that this tech is rolled out more equitably and helps more people to get the help they deserve and the better outcomes they deserve.
Yeah, I totally agree with you, Dan. And some of my experience has been also on meeting the consumer, the patient, where they are. So our most successful pilots have been where we've used current social media channels to engage the consumer. Where you needed to download another app, we found that the fall-off rate was 87%. So if you can meet people, we're working with some very interesting companies that meet people on WhatsApp, Line, Facebook Messenger, and other places. And the reason I raise this here today, Dan, the comeback that we get is, but how can I ensure data privacy on these platforms? because that's where the consumers are, and they don't want to download another app. They want to talk to you there. And what do you do with that? So Dan, can I come back to you? And I'm not asking I'm not asking for your legal brain on this.
No, and I'm not sure I'd want to volunteer it here. But I mean, look, it's a huge problem. And as I said earlier, that the data protection laws, GDPR, data protection legislation in the UK has to be reformed. We've recently had the white paper on innovation here. There is recognition that this has to move forward. If you're going to have information sharing and you're going to use various platforms to do it and to have the interoperability. I mean, obviously, I'm thinking about in particular the overlap and interlay between the health system and the care system. The care system is drastically falling behind in terms of the innovation and digitization, and that's got all sorts of issues that I've already talked about. Investment in certain areas because it's more difficult, less profitable. But there is no doubt there is going to have to be a revamp of legislation and indeed of the regulation and the regulators' role in this area before we can truly become digitized and integrated across the healthcare system.
Thank you, Dan. Moenia, you wanted to come in on this.
Thanks again. So a lot of very interesting threads here, and a couple that I want to pick up on. And you said something, Niti, very important, is about the countries that don't have the data. What do we do about them? And also, for me, this speaks to the issue of strengthening health information systems. Digitization and health information, of course, very closely related, as we've discussed here today. And just to mention here that the WHO recently released what they call the SCORE report. And the SCORE report is a report on the global, it's a global report on maturity of health information systems across 183 different countries, representing approximately 87% of the world's population. And one of the key outcomes of that report was the finding that about 40% of deaths globally go unregistered. In Africa, of course, the number is a lot higher. It goes up to 90% in some cases, on the African continent. So you can imagine what that means in terms of responding to a COVID pandemic, for example. If you're not registering your deaths, how on earth are you able to make policies that respond effectively to your pandemic? And again, going back to the recommendations from that report, one of them was indeed the need to strengthen data governance and data sharing regulations to improve data access sharing and enable us to translate data into policies. And just finally needed to close on this, one of the key areas we're going to need in able to achieve all of these goals is, of course, improving collaboration. And I mean collaboration across the board, across all different relevant stakeholders. Sinead mentioned the private sector, and the private sector is engaged in health in a lot of different ways, be it in healthcare education, healthcare financing, service delivery, or logistics management. The private sector needs to be engaged really across the entire continuum of healthcare. Also linking back to our engagement with multilateral organizations such as UN agencies, WHO, etc. Research and academia, civil society is very important, and of course the donors and the financing sort of entities. So important just to link all of the different collaborators across the board and work together that way. Thanks.
Oh, absolutely. Easier said than done, right? Everyone's living in their own little world sometimes. But I think the pandemic, as you said, Moenia, has brought people together in terms of finding those solutions. And I'm hopeful that those solutions will be found together. I'm going to move on to a different topic. And I think we've touched on lots of golden threads here. I'm so grateful to you, panel, for being so lively about this discussion so far. I'd love to keep the energy up. We're getting lots of questions around outcomes. But I'm not going to open up that can of worms right now because I'd like to stick with the digital theme. I guess, Steve, here's one for you because I think people are talking about outcomes quite a lot. In every country I go to, people talk about it. Perhaps you want to run a different panel on that. I'm sure lots of people want to contribute. So just coming back to digital trends, and we talked about how many consultations had been converted. I know in the UK about 80% had been converted. When I started doing this 17 years ago, everyone thought I was bonkers, and I got reported to the GMC for doing this, for dumbing down general practice. But here I am, I'm still living to tell you a tale. So just coming back to that kind of, is it a fad? Is it a trend? Is it something that we're going to see more of as recovery and restoration happens? Are people going to go back to the norm of, thank God it's all over, and now I can get back to seeing my patients face to face, which is also kind of a thing that, I experience that some days. I've got 5 medics in my family, and I hear this all the time on the dinner table. So just coming back to that, what is the panel's view? Is this a fad? Is it a trend? Is it here to stay? How much of it is going to be a click? How much of it is going to be a brick? Who wants to take the first stab at that?
I'll happily jump in, Nitty. I think you've asked the $1 million question that I'm sure all finance planners, all strategists, all governments are looking to ascertain an opinion on. I think for me, it isn't a fad, and I think it isn't a fad because it's gone on longer than a year now, and behaviours and habits have been formed in that process. I think there's a level of uncertainty of how much we retain in the digital space and who chooses to interact with the digital space going forward, whether it's the elderly population or the young population or the middle-aged population is to be determined. It may even be a cross-cut across all those segments of the population. But I think interesting for me is that the key realization that for digital, the combination of physical and digital sounds like an absolutely dirty word. It's not meant to be. For digital, is the combination of physical and digital environments is the way forwards. And embracing technology within the for digital environments to provide that continuous monitoring or that holistic perspective of a patient or a consumer in the system is critical. And I think once governments have latched on and payers have latched on to, as they are doing so, the fact that for digital is actually a way to not only generate cost savings, but you can also create effective and more effective health outcomes through nudging, through communication, through empowering patients and consumers with their data and their own health behaviors. I think it will take off. So for digital is where I'm going to put my Bitcoins on.
Yeah, me too. Yeah, Simon. Yeah, that's another one, right? The Bitcoin. We'll talk about that in a minute. Simon, Stan.
The conversations I'm having is that this is actually going to be very nuanced and very complicated. There are some things where digital first will be the default. There are some things where digital modalities don't work. My background is as a surgeon, and there aren't many surgeons who would see a preoperative patient remotely for anything other than the most minor condition. And I think we will find some of what's been done 80% remotely over the last year accelerates to 90 and 95. There are some things where it drops right back to 20 or 30. And I think different activities will find their level. And I think that level will differ quite significantly between groups within a population. And thinking of the work Senate and Mwanya are doing very differently between different countries and different populations within countries. And I think people will find their level, and then they'll be learning between countries, between services. Okay, in our population, this activity we're doing 10% digital first. In that country, it's 40%, 50%. Do we want to get there? And if so, how can we do that? So I think there's going to be, an extended period, many years of forming and norming and working out what the new normal looks like. But it's certainly not the old normal.
Yeah, for sure. The question, again, I get a lot from clinicians is, and a lot of clinicians say this to me, oh God, I just want to go back to my face-to-face consultations. This is just far too stressful, is also what we're hearing. So, and this is from people on the ground saying this, and I get that. But I think it's, like you said, it's norming and forming. But the question again, and I'll bring you in, Stan, the question I have is, while that norming and forming is happening, it's so easy to go back to where you were. And how do you actually stop that in terms of using consumer behaviors that we've just spoken about? The banks went into it very quickly. And I think, Stan, you touched on that. So I'm going to bring you in here.
Yeah, thanks very much indeed. I think my simple answer will be the same as in the non-healthcare world. Digital will simply become dominant. The reason for that is the benefits of digital transformation and finance, retail, travel, insurance, they've all gone through it. And we're sort of taking our first stumbling steps in healthcare. They did that to get lower costs, greater efficiency, and improved customer satisfaction. And if you look at, we analysed what were the two key lessons from digital transformation in all those industries. The first one was the industry as a whole had to move from organisation-centric thinking and systems to consumer-centric thinking and systems. What I mean by that is, if I had a bank account with Lloyd's in London, I could have 4 accounts in Birmingham, 3 in Glasgow and 2 in Cornwall, and they would never know, because all their systems were account centric. If I had with a Prudential insurance company, if I had a home policy, a home insurance policy and a car insurance policy, and I moved home and told the home people I'd moved, they didn't tell the car people, because all their systems were policy centric and they couldn't read across. They had to go through an enormous exercise to have a longitudinal consumer centric record for all of their customers across all of their industry. But that made a substantial difference. So number one, the industry must move from organization centric thinking and systems to consumer centric. And the second thing they discovered was that you allow the consumer to manage as many of the services directly themselves as you possibly can. And to do that, the consumer has to have their own lifelong record. So on Amazon, if I remember, I bought something 3 years ago and I can't quite remember what its name was. It's dead easy. I go into my longitudinal record in Amazon. I see it back 3 years ago, click, I order it again, because Amazon have got for me and given me complete access to it, a complete historic record of all my interactions with them. In healthcare, we have neither. We're still organization centric and we do not allow the consumer to engage. Those trends are inescapable consequence or inescapable things you have to do to get the benefit of digital transformation. So I think we're past the point of no return. I think we will still have a mixture. I take Simon's point, of course. There will be a mixture of online and bricks and mortar in healthcare, as there are in many other industries. So John Lewis has a great store and it has a great online presence. There's nothing, it's not one or the other, but the mix will increasingly go digital. If healthcare resists, then consumers will do it anyway. And the water will divide around the feet of doctors and nurses and join up on the other side. It's inevitable.
Yeah, so Stan, I think we get the message around that. So my question again, and John, you may want to answer this, or perhaps Emma, you might want to take some of this, is what I'm also seeing around the world is the physical changing. So the brick is also changing. So when I talked about the click and the brick with interacting with each other, and Anushka, you articulated that very beautifully on that physical and digital coming together. But I'm also seeing the trend that I'm seeing across the world is the brick changing as well. So very interesting models that I've had access to a company called Saver Mobile that I've been advising for years. Their pop-up clinics have a community healthcare model. A doctor in a suitcase takes a point of care testing diagnostic, 20p for 10 tests. A very different kind of model. We're seeing many of these kinds of Reach 52, another company I'm working with. So many such models, aggregator models, Najacare in Nigeria. So lots and lots of interesting models around the brick shifting as well. So my question to you all, and John, perhaps you first, when that interaction between the physical and the digital happens, the brick also has to shift. Are you seeing any trends in that? Are you finding any investment trends that are happening there?
Well, that's a big question. I think that I'm involved with Stan in a business where we're actually just doing this. We're combining a group of businesses where we're putting a digital platform together to manage them. The businesses are changing drastically within what they're doing in the traditional area, and they're looking for other services to increase their functionality. In the seniors market, up until the COVID hit, we were looking at a long-term business idea I've had of putting a fitness center specifically for the over 50 population, where we would combine a private health service, a gym, a catering business, and an educational business together to supply all the services that the pre-retirement and post-retirement community would want, and an off facility service for those that are older in care homes and stuff. So I think there's a company in the US that I found has almost the exact business plan called Nifty After 50. And if you look at Nifty after 50, they do everything from teaching seniors to get their driver's license, dating services, travel. So, and it's a health, it's basically a health business looking after not only the physical, but the emotional and psychological health of their clients.
Thank you, John. So really interesting models there. And Emma, in your intersections on health, pharma, life sciences, and digital, have you seen anything evolving around this interface?
So I think that what I've seen is where physical products are starting to have a diagnostic element to allow people in their own homes to know what's happening. So, for example, urine diagnosis with sampling kits with a test that's sort of attached to them, and that allows more sort of at-home diagnosis and then acting upon that information. So that's what I'm seeing, and I think how that sort of shifts then. You know, we talked about it's been a year, but it's also only been a year.
Yeah,
and, you know, I think what we haven't yet seen is who is left behind, either in this country or in other countries. You know, who is left behind? What are the unintended consequences here? And how can we analyse that? Because we know that out of healthcare, you know, in credit or in other areas, there are unintended consequences. So how do we make sure that we kind of replay that back in this kind of timeline and make sure that we're making the kind of best decisions around diagnosis? Because there will have been things that you know, that aren't as we intended fully. And I think it's that reflection, you know, and that kind of data and information, which will then play out into your question, Niti, and kind of see how that transpires over time.
Thank you so much, Emma, for that. Mwenya, you wanted to come in here.
Thanks, Niti. So your question was, can digitization here to stay or not? And I see that question slightly differently. In my mind, is the question is, can digital health push progress towards universal health coverage? Yes or no? And of course, in a lot of ways, the answer to that is yes. We know, for example, that about half the world's population lacks access to essential health services. So of course, digital health has something to contribute in terms of mitigating that. But I also want to put in a word of caution, Niti. There's going to be a few problems that come along with this global push towards digitization. One of them is the issue, of course, of legality. We've spoken about that today, the legal framework, you know, around digital health, you know, access, but also the interoperability, I think, should be considered. Again, in the area of work that I cover, we've spoken very much with different countries across the world, mostly in sub-Saharan Africa. And we found out that the Ministry of Health of Botswana, for example, had about 35 different electronic data systems in use. That's one Ministry of Health in one country, 35 different electronic health systems in use. That really brings a lot of associated problems, you can imagine. The fragmentation that is going to come of that, the confusion, quite frankly, that is going to come up, that also needs to be mitigated and looked out for. I'll stop there, Niti. Thanks.
Thank you, Mwenya. And I think this is picking up on the point that Stan made around the patient being the repository of their data. Certainly in some of the countries that I've worked in, and particularly India, we find that wherever you go, they give you access to your data. So I had a lab test. I got given a portal. I could put everything I liked on it. I could upload everything I liked on it. So new brick models emerging is what I would say to you. Some of those providers of healthcare may not be your traditional hospital or your clinic. They may be your pharmacy, they may be your labs, they may be all the other things that we've talked about. And that's what I was trying to get at in this kind of shift that's happening. On the universal healthcare question that you've just raised, Mwenya, so important, isn't it? That improved accessibility to healthcare. So, Dr. Senay, I'd like to come back to you on that universal healthcare question. It is one of the Sustainable Development Goals, still is there, and rightly so. Tedros has stressed on it. Lots of people have talked about the universalization of data, the universalization of access. How do you see this play out in universal healthcare delivery? And again, Simon, this will pick up some of the points that you made around data, because in a lot of the systems that I've been in on looking at the payer provider responses in universal healthcare, they get stuck. They're like rabbits in headlights because they don't know where the data is. So Dr. Senay, back to you.
Thank you. I think I would like to agree with most of the panelists in Mwenya saying that regulations and standards are critical also for the new emerging societies like our service. But regarding the link and the relationship between the universal health coverage and can digitalization accelerate the progress towards universal health coverage, I believe that is a strong yes. But again, we need to kind of mainstream the digitalization initiatives in every programs and initiatives that we implement, from the primary healthcare, from the community healthcare, up until the tertiary and advanced healthcare deliveries. We need to mainstream our initiatives, and the digitalization component has to be mainstream, including the equipment that we install, the education, the social mobilizations that we do. We need to engage in digitalization. I think that is the way forward, and given the efficiency and the satisfaction from all the playing actors, the patients, the providers, and the government, and the private sector, and the insurers, and everyone, I think digitalization is here to stay. But we need to be really critical on the regulation and the standardization of the technologies that we implement, and also the protection of patients' information. And those are the key things that we need to care. Yeah.
Thank you, Dr. Zene. Really, really great comments. So we've got 10 minutes left. I'm getting some things in the chat. We raised a lot of questions around outcomes. So I don't suggest we open up that right now, because I think it'll just take away from the topic that we're discussing. But in the last 10 minutes, I want to give you all a chance to comment on my final, I hope, possibly $1 million question. We've seen during this pandemic, and John, I'll come to you first on this one. We've seen a lot of investment, the largest ever investment in digital healthcare and biotech, particularly biotech, because of what's been happening and this interface of data, personalized medicine, bringing together genomic data sets, layering pharmacy data, layering technology data from labs and from imaging to create new treatments and new things for the future. So we've seen a lot of investment in this. What do you predict? And I'd like to ask each of you this question, and you can say what you like on your last final minute or two. What do you see the next year bring? The immediate next year bring, John?
So that's whether the rest of the world sees this is what I see, is that I have, I think, as I've hinted, I've worked with Stan Shepard quite a bit, and we came together with a very clear understanding of putting the patient at the center. And I was coming from the physical side, my background being in kinesiology and fitness, and an international athlete. It's always been the fitness side, and Stan showed me the digital side, and I even came up with a word for Stan. He's never used it, but POWER, spelled POWHER, personal, online, worldwide healthcare electronic record. and I'll steal another line from Stan, because I say this all the time. The definition of a national health service is the management of 60 million care pathways. And I see the development of electronic care pathways in all those various issues that face people in their management of their aftercare of their health once they've gone through that treatment. I've just gone through a prostate cancer treatment. I'm now working with a dynamic lady who set up a company that's working with breast cancer aftercare called Buttress Bear. And she has figured out how to add the commercialization and profitability to make impact in social good. So I think that for me, working in developing and investing in care pathways and specifically in the aftercare area to help people get back to work.
Thank you so much, John. Can we try and keep our answers really brief now, because we've only got 5 minutes left. So I'm going to go to Dan. Dan, your prediction for the next year? 1 minute.
I mean, on the basis of what we've seen this year, continued deal activity, lots of instructions coming in or on products and solutions that will continue. I mean, the pandemic's not over yet. So those solutions that are going to continue to assist with social distancing and keep us safe doing that. I think then looking at the integrated care agenda here in the UK, I think there has to be more investment and more levelling up of digitisation of the care sector, whether that is care homes or in-home care, so environmental, remote monitoring, all of that sort of stuff. If we're truly going to see digitised integrated care here in the UK, that has to happen in my view.
Thank you, Dan. Anushka.
Great question. So I'm going to provide a different perspective. I see us scrambling in the next year to deal with the economic, environmental and social consequences of the pandemic. I think there's several areas in healthcare in particular that will have environmental and economic impact. The three I want to call out are the burden of cancer and what COVID-19 has done to cancer services, particularly in the UK, but also globally and worldwide, and the impact that will have on various segments of the population. Mental health is another key area that I see being, an area we have traditionally always ignored and or stigmatized. How has the COVID-19 pandemic changed that? And I see positive moves and shapes in that area with the introduction of digital services, but we're still far off dealing with the actual burden that is mental health within our population. And then I see fertility being another area which we don't know what the pandemic has done there and how it's necessarily shaped it, but it will have an economic and environment impact. So I reflect back and I see this being a year, the next year, of us scrambling. But I hope following that scramble, we can better leverage data, collaboration and technology to deliver efficient healthcare services.
Thank you, Anushka. Simon?
So I agree with Anushka that I think the next year is going to be messy. And I think I'm add one more to her list of three, which is workforce. I think globally the healthcare workforce is burnt, and I mean I know an awful lot of individuals who are speaking to me about, I don't want to do this anymore. Simon, can I have a job? Because they're a clinician and I do data about healthcare, and they see that that's actually much nicer than what they do now.
Got it.
And I'm sure many of you on the panel are having many conversations like that with friends and colleagues. So I think, part of what Anushka said about mental health, but mental health in the healthcare workforce.
Thank you, Simon. I think we've got about 2 minutes left, so I'm going to cut you short. I'm not going to, and I just want to, Stan, Emma, Mwenya, and Senai, please come in. Just quick thoughts, please. We've literally just got 2 minutes left.
Right, I'll do 30 seconds.
Yeah.
I think as far as COVID is concerned, we don't need to be thinking about what we would do next time. We've got to be thinking about what we will do next time. The world suffers multiple epidemics each year. There will be more and more pandemics, and so we have to be just as digitally prepared as we must be PPE, etc. We've got to be digitally prepared as a strategic national and international resource, and it will not surprise you to hear me say that I think one of the contributions to that will be citizens having their own portable, comprehensive personal care records. Thank you.
Got it. Emma.
Yes, I would like to maybe not make a prediction, but a wish that the amazing technologies we've got to manage conditions kind of get accelerated into looking at those going forward. So prevention rather than cure and management. I'd love to see some of that data being applied there.
Thank you, Mwenya.
Thanks. So, I mean, you've said it's not only the pandemic is not yet over, but as well as that, it's not going to be the last pandemic. So really, I think for me, the last word is the digital health economy is really going to play an increasingly important role in building back better systems, in inclusive economic growth, and ultimately in sustainable development. Thanks.
Thank you. Sanae?
Well, mine is also kind of a wish. I think the coming year would be where we can create an ecosystem for further collaboration and harmonization of the efforts so that we have a better response. Yeah.
Thank you so much. Thank you, panel. You've been an amazing, amazing, amazing panel. I've learned so much from you today. I've really enjoyed interacting with you. Steve, what a great panel you brought together here. I look forward to keeping in touch with you and all the panelists. I have tried to incorporate the panelists' questions into what I've asked of you. I hope you've enjoyed today as much as I have. Do join us on the rest of the World Health Festival that Steve has so nicely put together. Thank you so much. to both the panelists
Thank you.
and the participants.
Thank you so much, Nitty, and I think we have to salute you for wrangling such a large and interesting panel. I think you kept that moving so brilliantly. We've had so much that we can learn and that we can listen to from this morning's session. Thank you so much. That's it for this week for the Healthcare World Festival. Join us again next week. We've got an amazing panel on Tuesday, same time, same place, on the future of aid funding in a post-COVID world. We also have a brilliant session on Wednesday on the role of the UK NHS around the world. So join us for those. Thank you so much for being part of this morning's session. Thank you to the panel. Thank you to the audience. Thank you for all your questions. It's been brilliant. We'll see you again very soon. Thanks very much.
Take care.
Bye.
Bye.
Bye.